Good morning. My name is Dennis Carroll. I will be the moderator for this session. Let me first, on behalf of the Prince Mahadal Awards Conference, the Foundation, the Secretariat, and the International Organizing Committee, welcome everyone to Harnessing Technologies in the Age of Artificial Intelligence to Build a Healthier World. Over the past 20 years, we have experienced an explosive revolution in a range of technological and scientific discoveries. We've seen dramatic advances, as we heard earlier this morning, in genomics, areas of synthetic biology, information technology, which have been radically transforming the lives we live in every corner of the world. But as we look to the next 20 years, we find ourselves likely at the cusp of one of the most extraordinary and transformative revolutions in our species' lifetime. The emergence of artificial intelligence is not the first time we've had disruptive, innovative technologies. We can, from the beginning of harnessing fire, to the splitting of the atom, to the revolution, as we said earlier, in genomics and the information technology. Those advances have been profound with respect to our collective society around the world. But each of these was ushered in on a wave of anticipation of goodwill, progress, benefits. And many of those came true. But for each of those new, innovative, disruptive technologies and advancements, we've also seen they represent a double-edged sword. They bring benefits, but if not properly harnessed, and I use harnessed in the spirit of the title of today's conference, if they've not been harnessed properly, we have seen the consequences, the unintended consequences, which have proven in some ways even as disruptive as the positive impacts. We need look no further than the revolution in information technology. I think we would all agree. 30 years ago, as the World Wide Web was beginning to entrench itself in our daily lives, we saw it as an opportunity to build a global village. It was a tremendous step forward. But what we also saw was left unchecked, unguided, unregulated. We live in a world today that, rather than being a global village, the World Wide Web has become a source of fragmentation, disruption, conflict. So as we move forward into the rapidly changing contributions made by artificial intelligence across all aspects of our lives, but for the purposes of the next several days, thinking specifically about the consequences of health and well-being. The question we have from those earlier experiences, are there lessons that we've learned or should have learned that as we look towards AI, there are lessons that may guide us about how do we get the full benefits. In the spirit of this conference, it's about the equitable, sustainable, affordable, and appropriate application of AI and the building of new technologies. How do we achieve that in a way that benefits the many, not the few, benefits all, not the one? How do we make sure that we achieve a world that brings us again towards that collective well-being at every corner? So over the course of the next 2.5 days, we're going to take a deep dive into the range of issues and challenges and opportunities, the experiences that we've accrued, to be able to, in the spirit of PMAC, not just identify the problems, but think about solutions ways that we can tackle this going forward. How do we build alliances? How do we formulate policies and regulations that ultimately give us the kind of guardrails that incentivize further development in AI and its contribution to new technologies, but also disincentivize the negative aspects. So to start this off, Plenary 0, we will start with a formal presentation, a keynote presentation by Ruben Pillay, and we will follow that up with an informal fireside chat. We don't have the benefits of a fire, but use your imagination. We could probably, trigger your inner AI to imagine a fire that we are sitting around. And the panelists, in fact, represent the keynote speakers for each of the subsequent plenaries, Plenary 1, 2, and 3. And it's an opportunity for us to explore these in greater detail. We will also be inviting Wen Cheng, who we've introduced today in his very welcomed presentation this morning. So what I'd like to do first is to introduce our plenary speaker. Ruben Pillay is a professor of health innovation. He's the Assistant Dean for Global Health Innovation and Chief Innovation Officer of the Health System of the University of Alabama at Birmingham School of Medicine, Alabama, United States. Ruben, I will turn it over to you, and we look forward to being challenged, enlightened, and ultimately inspired. Thank you.
Thank you so much, Dennis. I really appreciate the opportunity to be here this morning, and I know the awardees, the laureates are not here, but I want to congratulate them on their phenomenal work that they're doing, and also to our fellow panelists who's doing exceptional work in trying to democratize access to genomics and, of course, all of the omics as well. What I want to do over the next, say, 30 minutes or so is take you on a really quick journey into what I think the future of health and healthcare is going to look like. All of this driven by artificial intelligence and digital technologies. I'm always accused of being an eternal optimist. But I can tell you we have never been in a better situation at a better time to radically improve the way we have been delivering care up to this time, from a cost, from a quality, and from an access point of view. I often begin my presentations, if I can get that to work. I often begin my presentations by a quotation from George Bernard Shaw: "The reasonable man or woman adapts himself to herself. The reasonable man or woman adapts himself to the world. The unreasonable one persists in trying to adapt the world to himself or herself. Therefore, all progress depends on the unreasonable man or woman." Now, let that sink in for a bit. I think, consider that what George Bernard Shaw says over the next day and a half or 2 days as you deliberate on how to address the global health challenges using technology and artificial intelligence. I think the time for reasonableness and incremental improvements in healthcare are actually over. The time has now arrived where I think for the very first time we can start talking about not just a healthier world, but a world of perfect healthcare. How can we leverage technology to achieve zero cost in healthcare? How can we leverage technology to achieve zero harm? How can we leverage technology to accomplish zero weight? How can we leverage technology to accomplish zero exclusion? How can we leverage technology to accomplish zero emission? And I really want to put it to you that given the trends and the trajectories that we're following today, all of these zeros are within reach. So, health and healthcare has been characterized by innovation, research, and development over the decades. But as you can see by this graphic, we've actually suffered from a major problem of translation. We're littered. Just take a look at the number of publications, the amount of money spent on research and development, and what this graph shows that it really does not translate to outcomes. When you compare how digital technology has revolutionized pretty much every other sector, it begs the question, why are we not able to capitalize on this in health and healthcare? And I want to put it to you that this could be multifactorial. You often hear about the fact that it's regulation, it's the culture of evidence, etc., etc. And all of these are correct. But one of the biggest shortcomings in our ability to translate this digital technology into health outcomes is a lack of innovation and entrepreneurial thinking and action in health and healthcare. How do we actually take these technologies and be unreasonable, not just in our operating, but in our business models to really translate or transform health and healthcare? And that's what my short presentation is about. It is, what are the key vectors that are going to shape health and healthcare? How does technology impact that? And what can you do to actually embrace these trajectories? This is the problem in health and healthcare. This is an African proverb. A cat that dreams of becoming a lion must lose its appetite for rats. This is the problem in health and healthcare. We aren't able to lose our appetite for rats. And we consistently and continuously make incremental improvements to a system that ultimately does not achieve the ultimate goals of cost, quality, and access for all. So what are the vectors that are going to shape the future of health and healthcare? A lot of the next 2 days is about artificial intelligence. I like to kind of frame it as intelligence-based medicine. And, I think for the very first time, we're moving into an era of true intelligence-based medicine. An era where for the very first time, we can actually use all the data out there to bring to bear on patient care. You may or may not know that on average, we only use about 5 to 10% of all of the data that there is in clinical decision making. The era of intelligence-based medicine is the era where we can start using a whole lot of this data to make decisions. And this is cross-cutting across the board, from improving quality and safety in health and healthcare. And of course, the challenges that we face in terms of quality of health and healthcare. It could be helped to improve the actual patient experience in hospitals. We can use artificial intelligence to improve operations. This is an example of using computer vision to optimize the workflow in an operating room or a theater setup. We can use artificial intelligence to improve the patient experience. These are some of the kind of quintuple aims that we're trying to achieve in health and healthcare that we've not been able to achieve in the past. And the patient experience just does not begin in the hospital. You've got to look at industries like the transportation industry and see how autonomous vehicles can actually transform access to health and healthcare. And by the way, we're working with a lot of hospital groups at the moment in the US to integrate, solutions like Waymo into their strategies to improve access to health and health care. Even within the hospitals, you can improve mobility and access by using the convergence of artificial intelligence and robotics, as shown here as well. And in China, I just learned that they're using actually robotic dogs to transport patients as well. So just some examples of how AI and its convergence with robotics and other components can dramatically change health and health care. But AI's biggest impact is going to be at the level of individual health and health care. Its ability, when coupled with human physicians, hopefully to improve our ability to diagnose, to treat, and to prognosticate. And you can see it helps us do two things: practice deep medicine and practice collective medicine. Practicing deep medicine means we can now, for the very first time, see things, patterns and trends that historically we couldn't. This is an example of what you can see in a plain chest x-ray, that you can actually diagnose a predisposition to diabetes and cardiac risk from a simple chest x-ray. Okay? Other examples of deep medicine are some of these things that I have up here, that you could actually diagnose Parkinson's from breathing patterns, or just from studying breathing and respiratory patterns, diagnose different types of respiratory conditions. That's what I kind of call deep medicine. It also allows us to practice collective medicine. How do we bring to bear all the knowledge that there is out there in our decision making to improve the quality of care? Now, this is, one of the most cited publications out there. While most published research findings are more likely to be false than true. This is pretty scary for an evidence-based profession. The essence of this article, I encourage all of you to pull this up by John Ioannidis sometime, is that when you actually run simulations of all of these publications out there, we find that the research claims are more likely to be false than true. And of course, this assertion is pretty scary. And, the essence of this is a lot of our clinical guidelines and evidence-based approaches to medicine are based on research that ultimately demonstrate correlations and associations between variables and not causation. Well, for the very first time, we can now take all of these studies and run meta-analyses of them and bring all of that knowledge to bear in clinical care. Of course, this is the classic example that's triggered this whole kind of AI frenzy in healthcare. This is Watson. It's become much better. It's not kind of the show child for AI, but it's become much better at it. Now, this is the power of AI, that it could use every publication out there, every clinical trial out there, every single bit of medical record out there, and actually compare that to the patient that you're dealing with and help you make decisions. So that's the real benefit of artificial intelligence. To me, I think one of the biggest future benefits of AI is going to be this ability to practice precision medicine. Now, you may or may not know this. What we practice today, and I speak to you as a physician, is imprecision medicine. Take a look at this slide. 10 of the most widely prescribed drugs by dollar or expenditure only works for 10% of the population. Okay? So it's a pretty scary statistic. Not only is it an issue in terms of how we practice or an issue of efficaciousness of medical practice, it's also a public health hazard. But for the very first time, I think what we're going to see is this ability to mass customize personalized drugs. This ability to actually design drugs for every individual. I mean, at the moment, what we practice is medicine that is based on the average patient. I'd like to ask you a question. How many of you in the audience describe yourself as an average patient? How many of you? Well, you shouldn't be, because each one of you is genomically unique, phenomically unique. Your lifestyle, behaviors, environments that you come from are unique. Medicine has never had that ability to treat you as that unique person that you are. But AI is going to enable us to do that. So a lot of potential to radically transform health and healthcare using artificial intelligence. What are the other key vectors that are going to shape health and healthcare? Well, one of it, driven by this technology, is what I call prosumerization of health and healthcare. Now, if you haven't heard the term before, I coined the term to describe the future patient. They're not passive recipients of care, nor are they going to be informed consumers. They're going to be prosumers. They're going to be technology-enabled producers of care. This is the future. So if you're trying to design a health system or practice in a health system where patients are customers or consumers, well, you need a radical rethink. Because the future patient is actually going to be your competitor, enabled by technology. This is an example of prosumerization. You know, the convergence of hardware, software, biology, and communication technology is democratizing and commoditizing access to medical technology. Technology that was once the purview of specialists and medical professions are now in the hands of patients. So the unreasonable approach to the future of health and healthcare is, how do we design a system where patients and individuals become an integral part of care delivery? Because we really do not have the capacity and capability to address some of the structural and workforce issues in health and healthcare. This is another example of prosumerization. You know, this all of pretty much every one of you in the audience is sometimes going to need an optometrist. The question is, you know, do you really need one? The answer is no. There's a host of technologies out there that actually enable patients to deliver their own services. And by the way, this device is a princely sum of $30. So for $30, you could become the neighborhood optometrist. You're a prosumer. You're not actually a patient. How about this solution for assessment of dental conditions? You attach it to your smartphone and essentially enables you to diagnose dental conditions. Okay? These individuals who use this, folk, are not patients. They're not consumers. They're prosumers. So the key is to integrate them. You know, the cultural, iconic symbol of medicine and healthcare has been the stethoscope. Well, the stethoscope is now commoditized. Okay, this solution, SteadoMe, essentially places the stethoscope in the hand of the individual, elevating them to become primary care physicians. Okay, this is enabled by advances in sensor technology and artificial intelligence. So if we're trying to design a system for patients or for consumers, I want to put it to you that I think we're asking the wrong question. Bear in mind what I said to you at the beginning. The time has now arrived for an unreasonable approach to health and health care. How about this? The commonest diagnostic out there, the X-ray, is also now commoditized. Patients can actually, you know, deliver their own X-rays. And one of the take-home points from this morning's lesson in terms of how the costs are dropping, this is one of the characteristics of exponential technologies. Prices drop with time. Things become cheaper, faster, better. We're actually seeing before us the commoditization of medicine. Okay, even a host of diagnostic tests can now be performed by smartphones. iCalQ, one of the world's leading companies, by the way, has a host of tests that you could actually conduct using your smartphone technology. You may not have heard this morning, but a company called Illumina is actually developing a commoditized version of a genomic sequencer that will retail for about $1,000. Okay, so the ability for you to become a resident sequencer is real, and it's not too far in the distance. So you may say, well, Ruben, what's the point in doing the diagnostic if we aren't able to do the interpretation? Well, you can, because solutions like Doc.ai, which was an AI platform, actually helps you to make sense of that. You may argue, well, that for some things you really have to go into a hospital. Every one of you at some time, if you haven't already had 1, 2, is going to queue up for this. Okay, it's a pretty uncomfortable but necessary diagnostic. Even this could be commoditized. Okay, Medtronic's PillCam is an AI-driven sensor-based technology that enables you to administer colonoscopies on your own. Essentially, you go through a prep period, you swallow the pill, and with artificial intelligence, this is able to diagnose colonic polyps or risks of cancer. So you may say, Ruben, where do I actually get myself a pill can? The answer is, like everything else, where do you get it? From Amazon or eBay. And you can see for a princely sum of $99.99, you can actually get yourself a DIY colonoscopy. Just be alert, though. There are always, some entrepreneurs out there. There's one used one for sale, so just be careful when you see that, okay? Now, the same for gastroscopies. Gastroscopies are a very, very common procedure. And did you know that 80% of all gastroscopies show no disease? It's expensive, it's resource intensive, okay? But that era is over because I'd like to introduce you to the Pillbot. Okay, simple. Skip breakfast, swallow the bot, 10 minutes procedure, instant results. Artificial intelligence-driven, self-administered, commoditized gastroscopies. Folk, for a princely sum of $50 an investigation. Okay? So the era of prosumerization, technology-driven commoditization and democratization of health and healthcare is real. This is a pretty scary statistic. You heard this morning the incidence of cancers and the deaths from cancers. How is it possible that in 2025, we're still diagnosing tens of millions of patients with cancer for the very first time, and we're losing tens of millions of patients globally from cancer? Well, the issue is that 70% of all cancer deaths are from cancers without recommended screening options. So it brings into question this thing that we call science-based medicine. Okay? I have some radical thoughts on how we should be screening for cancers. But I think you kind of know me by now. And to me, the answer to eliminate cancer, and I use the term elimination deliberately, is putting screening in the hands of the patient. Prosumerize cancer screening. Okay? And enable patients to screen for themselves. There's a whole host of technology that now enables that. Once again, as I said, it's these converging exponential technologies that are making it possible for patients to do their own screening and do it when they require it based on their individual risk profile and not some kind of screening protocol that we have imparted to them. So cervical cancer, one of the leading causes of death, can be screened for at home. Breast cancer, still one of the leading causes of death in female patients, can now be screened for at home. How often should somebody be screened for breast cancer? How often? The answer is not when they're 40. The answer is it depends. It depends on their risk profile, genetics, family history, environment, lifestyle. It depends on that. And based on that, we should personalize and adopt a precision approach to cancer screening. Some of you in this room may require monthly screening. Some of you may require 10-yearly screening. But prosumerization of cancer screening is the future. And it's actually theoretically or practically possible for us to do that. So I really want to encourage you to start thinking about prosumerization and make this an integral part of designing the future of health and healthcare. One of the business model vectors that I think is going to shape the future of health and healthcare is what I call this platform-based approach to healthcare. Now, you're probably familiar with Uber and Airbnb. These are platform-based business models. Why do you use Uber and Airbnb? A couple of reasons. Costs are down and access to products and services go up. Now, I don't want to spend time going into the science or the actual kind of mechanics of business models or of platforms, but suffice to say, it matches demand with surplus capacity. That's all it does. And I can tell you, despite what you read and hear about, there's a lot of surplus capacity in healthcare. And it's maldistributed. And what platforms do, it would connect that surplus capacity with demand, irrespective of where that is globally. Now, in medicine, we're uniquely positioned to actually replace the supply side, take off the physician, or the driver, or the room, and replace it with artificial intelligence. And suddenly we are in a business model that can scale at zero cost. And suddenly, zero-cost healthcare becomes a reality, And then what you do is you take the demand side off. You actually remove the patient from the platform and you insert your digital twin into that. And then we're in a new era of medicine. Okay, your digital twin becomes your angel. Your digital twin, powered by data and artificial intelligence, becomes your angel. It becomes your protector. Okay? So you could see the potential for us to do that. These are just some kind of examples of platforms where we can automate the supply side. This is an example of the supply side being replaced by an autonomous radiologist. You upload your image, and essentially, AI actually interprets that for you. I can tell you that the health system of the future, the largest, is going to be the health system that employs no physicians and has no beds. It's going to be a platform that connects those resources across the board. In fact, our virtual hospital in Saudi Arabia is well on its way to being that. Medical automation, I think, is another trend. It's, that's going to dictate the future. And I know a lot of the discussions and deliberations over the next few days are going to be this discussion about physician or human in the loop. Well, medical automation proposes the opposite. That we can rarely scale medicine if we remove the physicians or we remove the humans from the loop. And by the way, AI is getting superior by the day, and humans, unfortunately, with time, tend to deteriorate. These are some examples of technologies that actually enable us to automate a lot of the diagnostics in health and healthcare moving forward. This is an example of, a robotic phlebotomist that doesn't only do the blood draw, but also does the analysis as well. This is an example of the world's first autonomous dental implant. This was done a few years ago in China. No dental surgeon around. Okay? Perceptive, by the way, is the first dentist-free dental clinic. Okay? Medical automation, this ability to leverage the convergence of artificial intelligence and robotics is going to be truly transformative. This is an example of actually getting surgical robots to learn from video imaging. And if we're able to do that, that's the kind of equivalent of LLMs. Okay, but it's a VLM. It's a video language model. So we can train robots just by showing it videos and enable them to do their own surgery. So these are kind of realities that you need to factor in as you deliberate over these next 2 days. Remember, what I said earlier on is that progress is going to depend on folk being unreasonable. So don't leave these 2 days with a reasonable mindset. McFordism is an approach to it's an operating model approach. It's this convergence or combination of standardization and assembly line approach to surgeries in hospitals. And this is an approach to scale surgical procedures. It's an operating model problem. It's not an issue of shortage of surgeons. I get that. Okay? But when you wrap shortage of surgeons around an operating model malfunction, you have a shortage of surgical expertise. So McFordism is an approach to do that. I implore you to look up the Aravind Eye Hospital. It's a classic example of assembly line surgery. And you can see if you adopt that, how access and quality go up. The Narayan Hospital does pretty much the same for cardiac surgery, and you can see the data on that as well. So think about the implications of operating models in healthcare delivery. One of the concepts I also want to talk about is the concept of how healthcare is paid for. Currently, it's on an insurance-based model. In other words, we pay to mitigate against ill health. That's a bad model. Outsurance is a model where we should start paying for health. And we can really start doing that now because, one, we have access to real-time data at an individual level. So we can actually calculate risk at the individual level. The ability to calculate risk at the individual level means that we can start rewarding people for health. You know, the autonomous vehicles companies does that. Tesla gives you a discount on your insurance if you engage self-driving. Why? Because the data is there that the car drives itself better than you do. Okay, so can we actually use that in health and healthcare? Now, Vitality in South Africa is one of the leading companies that does that. They provide rewards. You know, this is an example that actually does the same for dental insurance. Beam Technologies is a sensor-based toothbrush. So they have data based on your individual dental hygiene, and they titrate your premium based on your dental hygiene. Okay, that's outsurance. It's not insurance. And then, of course, we have other models as well. So, okay, we have other models as well. This is what Earn As You Heal. This is something we're piloting at UAB, where we're actually paying patients who participate in their remote monitoring as part of their chronic disease. We actually cut them a check, and adoption rates have gone up to 150% when we do that. The futures markets is another thing, another trend that I think is going to characterize the future of health and healthcare. I'll talk about that later on if I catch you in the at one of the socials. But I really want to end with the cure paradox, which is one of the trends that's going to shape the future of health and healthcare. We've become so good with the science that we're in the process of eliminating a whole lot of diseases. You heard this morning. You know, gene therapy is leading this way. 250 drugs currently on trial. We started the process of eliminating disease. So whether it's gene therapy, whether it's stem cell technology, or you know, look at this. The world's first case of diabetes being reversed, okay? We're on a path to disease elimination. And it begs the question, if we start eliminating disease, what's the purpose of our existence? Okay? And I want to put it to you, we're ideally positioned to make the transition from reactive sick care, episodic, to proactive well care and continuous. And you know, this is the science of what I call well care. Essentially, it's using, you know, the host of phenomics, host of omics, lifestyle data, environmental data, and doing this from womb to tomb. Okay, well care starts before birth. Well care doesn't start when you're 60 years old, okay? And this ability for us to detect biomarkers and digital markers, you know, before diseases manifest is really the key to the future of health and health care. We didn't have the ability to do that. We now have the ability to do that. So I think these are the vectors that are going to shape the future of health and health care. It's going to require, as I said, a radical rethink of what we define as a patient, who do we define as providers, and what do we define as health and healthcare systems. We really have to have a radical rethink. Okay? So what I want to do is leave you with a parting message, just to say that, you know, irrespective of how unreasonable it sounds, I think we can do this. We could get the volume up, I think. Well, the volume is not there, but I'll hand it over back to Dennis. Thank you so much. Thank you, Dennis.
Well done. Thank you.
Thanks, man.
Ruben, thank you very much. It's getting off to a great start. You certainly have given us a sense of what is coming. I think we'll now have a chance to talk about how do we get there in an equitable, sustainable way. So first off, I'd like to invite Hani Kim. She is the Executive Director of Right Foundation, the Republic of Korea. I would also like to invite Jean Philbit Nugget Imana, who is the Chief Digital Health Advisor for Africa CDC. Similarly, Meg Davis, Professor, University of Warwick, United Kingdom. And we already have Wang Jian, co-founder and chairman of BGI. You can look in the PMAC website to get a fuller biography of all of these interesting people. But I thank all of them for coming. Let's have a chat. Everyone has a Well, Ruben, thank you very much. You've given us a sense that AI isn't so much a thing of the future and the impact on technologies, it's here now. Certainly if you can get these instruments off of eBay. Right. The question that I would like to start this discussion, and I'm opening it up, again, the spirit, fireside, interactive, I disappear. This is an opportunity for you really to have a good, thoughtful, provocative, entertaining, and informative discussion. So my question is this: you've given us a peek into the world we would like to have, but we know we live in a complex universe. In recent weeks, we've heard how the AI investments is now becoming like the space race. We're now talking about an AI race. But when there was the space race between the United States and the Soviet Union, it was two countries that controlled everything in their domain. The AI race is, on the one hand, happening in a fragmented geopolitical world, but it's also largely not the purview of state governments. We are seeing this is coming out of private sector. So, the double-edged nature, you've told us what is the opportunity, but there are embedded in a lot of what you said some real issues that we have to struggle with. Privacy, appropriateness. Again, we're talking about a global population. So how do we make sure the technologies that are being invested in are to meeting the needs of, again, not the few, but the all? So I'd like to open up a question, and maybe Meg, you could give us a little sort of kickoff here. What do we have to be thinking about? How do we approach this? Right now, it's in a very chaotic, non-regulated environment. It's private sectors who maybe aren't interested in getting the best, the safest, the most sustainable products. There are other interests out there as well. Can you give us some thoughts first about what the challenges are, but we really, again, want to think about where do we go with this? How do we harness the potentials and avoid the unintended consequences?
Thank you. Thank you so much, Dennis, for giving me the easy question to start us off. That's not a small one. But I just wanted to say, first of all, what a great honor and pleasure it is to be here at PMAC, first time for me, and with such wonderful co-panelists. And at this really crucial moment, which I think the past week, for those of us who follow so-called global health, has been a tough week, with the US cutting funding, allegedly pausing, I guess we'll see, for life-saving medications in low and middle income countries. Devastating blow for many, and really caused, I think, many of us to reflect on both how important it is that we have that funding, but also how much we need to change global health and the existing institutions, which are so profoundly unequal and that are clearly not fit for the 21st century. And in that light, I think it's so wonderful that as global north countries potentially step back, that we have a country like Thailand stepping forward, welcoming us all to the capital, It's such warm hospitality. And Thailand as a public health system, I think that many of us can reflect on and learn from. Very strong, robust public health system with a history of innovation in the HIV and human rights space, which I'm familiar with. Lots of people talk about innovation, but Thailand has done it. They've had the first country in the region to have harm reduction and HIV prevention for people who use drugs. The first country to have compulsory licensing to ensure access to medicine for all. The first country to have a civil society principal recipient from the Global Fund. And now, as those of us who went to Rama Hospital yesterday heard, really taking thoughtful steps towards governance of artificial intelligence for good, with strong civil society engagement in every aspect of public health. And I think all of these experiences are things that we can reflect on and learn from as we look towards the digital future, the digital present. We need strong civil society participation. We need communities to be at the center of design of these technologies. With all that Ruben has shown us about what the future holds, it can't be an extractive model with data taken from Thailand and other low and middle income countries for profit in the global north. It has to be locally owned and developed. I could go on, but I'd love to hear from the others too. Thanks.
Philip, why don't we just move right to left, or left to right?
Thank you so much, Dennis. To your point, I want to join you in thanking our gracious hosts. There is a chance I couldn't be here because at the time of checking into my flight, I realized I didn't have a visa. But what happened in the next 12 hours was not short of extraordinary because thanks to seamless coordination, the visa was issued and flights rebooked and everything. So I really want to start by thanking from the bottom of my heart our hosts today. The question of the power shifting from big governments to being basically democratized. I think this is something that is significant. The other thing that happened this week, except the US government stopping or suspending aid, is also DeepSeek, which demonstrated that the old saying of US innovates, China copies, imitates, and then Europe regulates is changing dramatically. And because of the cost of innovation going down, innovation is going to start coming from places that we have not traditionally seen coming from. In the case of where I come from, in Africa, we've been for the longest playing catch-up on innovation, on these new technologies, missing the first, second, third, and fourth industrial revolutions. But I think thanks to AI, there is a real chance that Africa, the 1.4 billion people, also participate in producing. So talking about prosumers, we are going to start seeing producers of these technologies from places where you didn't used to have them. One of the maybe two things that I think about the most is, first of all, when ChatGPT came out about a year ago, it could not speak my language, Kinyarwanda. I used to have like a chat in my local language, and the kind of feedback I used to get was hilarious, grammatically correct, but completely meaningless. But today, it speaks my language to perfection, better than my grandma. And that means that people can have a chat with an AI chatbot in local languages and understand what's wrong with them, what they need to do. And those are people in the rural, most remote areas who have not had the benefit of interacting with a qualified, medical practitioner, never met a doctor in their lives, but now they have the entire knowledge of the world to help them understanding themselves and understand what to do about it. The second thing is, we've talked about personalized medicine, which is amazing, and the talk by Robin illustrated that. What we also need to be mindful about is inclusivity, making sure that we don't leave anyone behind. And I think AI gives us the opportunity to bridge sort of the cutting edge of personalized medicine with the universal access to care that many countries in developing world are still struggling with. And I think if we find a way to bridge the two, we will be on the way to a healthier world.
Honey.
Okay, at the expense of sounding like perhaps a little wet blanket, I'm going to bring in the lens of equity, health equity, which is something that Right Foundation thinks deeply about. We are, for those of you who are not familiar with the Right Foundation, it's a Korea-based funding organization that invests in projects to support efforts to develop and make available vaccines, therapeutics, and diagnostics. So I myself, as a trained scientist, I love getting excited about cells, molecules, precision medicine. But I do think that we need to step back, and I think Megan perhaps touched upon this briefly. I think it's extremely important to anchor innovation, not just AI, but innovation in general, in the values that AI itself cannot generate. We should guide AI towards certain values. And I think this point was well portrayed in the video in the opening session. I found quite powerful. So something like a value of equity or value of public health, they're not going to be built in any sort of innovation unless we guide it to achieve those ends. So the forum spends a lot of time about ensuring equitable access, which is absolutely necessary. But I would like us to push ourselves a little bit more. And Phil just mentioned that there's a movement or initiative among African scientists to not just access, but develop what they need. So I think when we think of equity, I think we should just challenge ourselves, go beyond simply ensuring equitable access, but ensuring that means of an innovation are owned and controlled equitably so that the ultimate end users in resource-limited settings, they define their own problems and they can develop their own module of AI algorithms that they will benefit them the most according to their very specific local context.
If I could pick up on your point, one of the challenges, I mean, Phil, your point about sort of Africanizing this process as well. I heard yesterday someone made the reference that if you want to see the future, take a look at patents. And when we look at AI patents over the last year, 60 have come from China, just about 30 have come from the United States, 0 from Africa. So to achieve that kind of engagement, to Africanize, how do we make sure that the algorithms are responding to African needs, African priorities? That's one question, but I also have a question about values. What we heard 2 days ago was that the chief officer at OpenAI that is responsible for ensuring that the algorithms that are developed have in parallel algorithms that imbue future AI capabilities as having human values, so they don't end up veering off in ways that could become hostile. The existential threats that we've heard about. The chief of that for alignment resigned. And he resigned because of the AI race. He said that everyone was focusing so intently on getting out ahead of DeepSeek, whatever the next iteration is, right? I mean, whether it's ChatGPT, then DeepSeek, everyone is throwing out, and we're going to see this just explosive. And he was making the point, it's coming at the expense of imbuing those algorithms with human values. So how do we, to me that's alarming. So for you and for others, maybe we can talk about that, but I'd be interested in this Africanization. Again, patents tell us about the future, 0. What do we have to do to change that?
The good thing with exponential growth is it takes time to really notice anything. Could be 0 this year, could still be 0 next year. But if we do the right investments, at some point it's going to take off. Because again, it's about patterns. I think the fundamentals for an AI society are also taking root on the continent. We are getting more and more access to electricity. Levels of STEM educations are going up. Access to connectivity is being democratized, and everybody in Africa has in their hands the mobile phone, and many people now are getting smartphones. Now, equipped with the smartphones, they can start contributing, if anything, their own data. Africa contributes 17% of the world population, but only 3% of the genomic data available, which means that all these algorithms are being trained on data which is not aligned with the characteristics of our population. But that is about to stop. So there is a government role in terms of investing and regulating or deregulating. But also I had a chat with Hani this morning about the role of investors, philanthropic investors, but also VC investors. And sort of reflecting about where is the money going? Are we putting the money where our mouth is? And I think if we embrace the co-creation approach, listening more keenly to what's the voices coming from the communities, fixing ecosystems, innovation ecosystems across the continent, then it's just a matter of time, and it will all take us by surprise when we see this hockey stick curve where more and more innovations, from 0 to 100, it won't take 30 years. It could take just 2 or 3 years.
And if, Honey, you could respond, but I would also, in a couple of minutes, like to turn it over to the audience to begin asking questions. And you'll note that there, within each aisle, there is a microphone. So in a few minutes, we will switch to the audience. And just to introduce yourself and ask a very focused, crisp question. If it's to the panel, say panel. If it's to an individual, say individual. But Honey.
I would like to share with you this one very exciting development. Speaking of African-owned innovation, so one of the grantees that Wright Foundation has funded, Kelly Chibale, a fantastic scientist based at the University of Cape Town, he and his team are leading this initiative to characterize genetic polymorphism, so genetic variations, to predict safe and efficacious drug targets, for example. And you wouldn't be surprised to hear that up until now, the vast majority of the genetic data, the African population, which are genetically most diverse on Earth, they're underrepresented in this genomic data. So what that means is this actually has concrete consequences for drug designers and developers, because in order for you to determine or down-select the best candidate to develop a drug or to determine a safe and effective dose, those parameters critically depend on a large group of drug metabolizing enzymes that will respond very differently to these drug targets. So I just want to say that already that kind of movement is already happening. I think it's such a wonderful initiative that's now starting in South Africa, and I'm sure that Kelly Chibale's group is not the only one, but we just have to make the efforts to listen, as you say, and note and support these efforts.
Thank you. Wang, could I ask you a question? Private sector representative. And I made the point that the private sector is going to have a greater role than it typically does in the rollout of AI. It is being funded by, driven by the private industry, more so than government. How do you see the potential of creating a more coherent, coordinated, unified private sector approach so that we don't invest and roll out AI at the expense of AI being able to achieve human values?
Okay, as the private sectors, I have something to say about the things and especially for this Africa things. For last couple of years, we trained more than hundreds of the CDC science scientists and technologists from the Africa. And we offer the free training and the courses, not only the genomics and the diagnosis, also the AI class. We set the biggest genome center in Cape Town, and to sequence all this. We know the variations in Africa is the biggest one, especially for the rare disease. We cannot transfer the standard from the China, European, and the US to Africa. We have to have the baseline there. So I think the most important is to set up some kind of platform and baseline for them to set up their own standard. And for AI training, and we are the follower, I think, and effort can jumpstart it. We took together, and what we talk about is most is the genomic is the baseline, and Robin talk more the phenotype for the clinical application is more close to the people and more easy to use and teaching people. But we need to put all the things together, from the baseline, from the genomics, from DNA to the clinical application. And AI is the linker. It's most useful tools to speed up all this kind of learning curve and applications. For the private sectors, we are a little bit different. We usually make the big mistake. I think that Africa is our duty to help, and then the people are laughing at us. So all of the profit in BGI to come back to the basic research and low-income countries. So we're sort of different and crazy, but we are happy to do this. So I think for us, we try to catch up and the train of for the future. So we're not only doing the basic research, also use the AI as a very powerful tool to speed up all this kind of things. So we are working closely with public sectors and the government and private sectors and also ordinary people. So we think the BGI is global citizens. We take all this, what we can do, we'd like to share and to help and make us so proud. And so if we can make enough money to survive, the rest of the money goes to the globally. So AI is very important.
Thank you. Megan, you look like you, I'm sorry, Meg. I have a niece, Megan, so it tends to be a two-syllable word for me. If I could ask, you look like you had something to say, and then Ruben, if you could respond to all of these issues, and then I'm going to turn it over to the audience, okay?
Yeah, thanks, Dennis. And I was really just reflecting on what Phil was talking about in terms of the energy and the hunger and the innovation that is really emerging around digital and AI in different parts of Africa. I'm lucky to be the principal investigator of something called the Digital Health and Rights Project, which is the largest international study of digital human rights in health, with young adults from Ghana, Kenya, Colombia, Bangladesh, and Vietnam participating in designing research, implementing it, validating the findings, and then using them for advocacy and training. And one of the things we found, which I think is important when we talk about AI in health, we have a tendency to focus on just the technologies used clinically, But for many of the young adults we spoke with, digital health for them means social media. It means TikTok, it means YouTube, it means doing searches online for symptoms and then trying to self-diagnose, which doesn't always work out as well as we might hope. And while that's very concerning in terms of misinformation and disinformation that those young adults are exposed to through algorithmically driven priorities, it also means that they are able, because there's zero barrier in terms of cost to entry, they can develop accounts which they use to educate themselves and their peers about health issues. And some have followings of hundreds, thousands, even millions of young people sharing accurate, for the most part, health information with them in a way that's youth-friendly and that really engages young people. And that to me shows two opportunities. And one is for the health system to partner with these young social media health champions to reach young adults who, frankly, if I go on TikTok, I'm not going to get more than 5 or 10 followers, to be honest. But a young person who understands how to use the medium can really use it well and powerfully. So that's an important opportunity. And the other opportunity is training, digital literacy, small amounts of investment to equip those young adults to actually develop the innovations that their communities need. Thanks.
And Ruben.
Yeah. I don't- Okay. Yeah. So many valuable points raised, and I kind of agree with all of them. So bear in mind, we're in a situation at the moment where there is no such thing as unethical or inequitable AI. You know, it's the actual algorithms are the manifestation of individuals who've designed them, who've coded for them, who deploy them, and who monitor them. So I think one way to mitigate some of the downside or risks is to ensure that, you know, people who are actually designing, developing, deploying, monitoring are reflective of you know, the people who are going to be the beneficiaries of it. That's the first thing. I think the second thing is the role of business versus government. You know, the reality is that pretty much 90 to 95% of all the AI development, whether it's product development or research, is happening in the private sector. Government is playing a very, very small role in that at the moment, and I think rightly so as well. So which kind of begs the question of what the role of government really is. And this is pretty delicate, you know, in terms of governance. But once again, you know, governments are a reflection of the people. And, you know, the policy frameworks should reflect what the population of that country really wants. And, you know, I have concerns as well that when we have discussions about governance and we have discussions about ethics, we're adopting global approaches. The reality is, you know, there's geographical distinctions amongst people. Geographic, demographic, everybody's perception of what's good and bad and right and wrong is not the same. So, you know, we're moving into uncharted territory, and I think we must recognize that. We must recognize that we've never cohabited with anything that's had superior intelligence than we have. We're moving into that space now. And my fear is we're using old and extant frameworks to govern and shape our thinking in a present and future that we really have no experience about. So, I mean, I think it's, you know, we got to radically rethink everything. The concept of ethics, the concept of governance. You know, is there a discussion to be had of personalizing it? I think it's possible. I mean, you know, my take is we're moving to a future where AI is going to be very personalized. We're going to be moving from large language models to small language models, where individuals will have their own models based on what their persona is, based on the way they think, based on their data. That's where we're going to go to. We're already, you know, on that path. So, I just, to the audience, just don't fall into that trap of using existing, try to rethink, it's that slide that I go back to George Bernard Shaw is progress doesn't come from reasonableness. Using existing frameworks and existing approaches is a very reasonable way to do things. And my concern is that may become more an impediment than a guide. So I'll just put that out there and hoping that we can stimulate some discussions around that.
Great. Thank you, Ruben. We have a little bit, Gabriel, I am mindful of there. Plenary 1 is coming right after us, so we don't want to shortchange them. So a couple of questions that people might have. Please introduce yourself.
Morning. I'm Gopal Ramcharan. I'm professor of AI, and I head an organization called Responsible AI UK in the UK. Question for you, and you mentioned, Dennis, the idea of the number of patents being produced in the US and China and the lack of patents in Africa. What about open source? Why should we not be promoting more open source approaches? We've seen DeepSeek is open source, Quen open source, and that's accelerated the AI race. Should we not be promoting open source in the healthcare community as well? Thank you.
Excellent question. I think, Meg, you're ready for this one.
I really couldn't agree more. I think we should be requiring open source, certainly for government-funded or UN-funded applications. But I would go a step further and to say not only open source, but explainable, something that we can actually understand, that we can participate in, judging, that we can't really have a meaningful democratic voice in governance of a technology that we don't understand. And that's going to require both digital literacy for all of us to understand these black boxes that are supposed to be so magically transformative, but also for software engineers to learn how to communicate with the broader public in a way that makes it accessible to all of us. And I would add open source, explainable, and also accountable. We need accountability because there are harms. It's no longer a question of risk. It's a question of actual documented harms. And who is ultimately accountable is a question I think we still need to do some work on.
Great, thank you. Jesse.
Yeah, thank you, Dennis. I'm Jesse Bump from the Harvard Chan School. I had a quick question for Hani. You mentioned the Wright Foundation funds diagnostics and vaccines and medicines. And in the COVID period, we saw that life sciences research was at an extraordinary place. And it was the other things that you mentioned, like rights, entitlements, ethics, that broke down in access. So I'm wondering, does the foundation actually make any investments in research or practice about how to distribute vaccines equitably? It seemed like in the focus areas, you're giving bigger advantages to the life sciences companies, maybe some of them charitable, but those are the ones that commercialized research and played some role in the denial of care. Certainly rich countries joined in that effort, but I wondered what the foundation might be doing about that. Thank you.
Okay, thank you for that question.
And
so
if I could ask, we'll get one more question, and that'll be the last question. You'll have lots of other questions, and fortunately what we have are plenary 1, 2, and 3, and you're going to have an opportunity to ask those questions there as well. So if we get another question back over here, and then Hani, if you could respond to that.
Hello, thank you all for this opportunity. My name's Carolyn Wallace. I'm from the Vic Health Foundation in Australia. I think the idea of personalised AIs is exciting, it's more focused, but my question is then to Meg about the risk, or how do you then, wouldn't that just build further media bubbles and that kind of isolation? How can we continue to be exposed to diverse and alternative viewpoints and experiences to keep ourselves connected as a society?
So Hani, why don't you, and then Meg, why don't you?
Okay, thank you for that question. Let me try and answer this in the next minute and a half so I can give enough time to Meg. So Wright Foundation funds mostly through three funding mechanisms. The largest one is the Product Development Award, and second is evidence generation, and the third is training. The short answer to your question is we don't have a separate funding stream to fund quote-unquote activities focused on improving access. However, strategically, we have built in our Product Development Awards detailed plan to ensure global and equitable access. So when our selection committee and reviewers evaluate our proposals, there has to be a very compelling argument as to how, whether it's a vaccine or therapeutics or diagnostic that you propose to develop, you will ensure equitable access. So that's how we address it through our product development award. It's built in so access is built in our product development awards. The evidence generation award is a newer funding program, and with this was really intended to be on a learning and listening mode. So this is, we see this as an opportunity to learn broadly about how Right could do better in funding these efforts to make these products in a way that is equitable, not just in, again, access, but in co-creation and co-development that Phil, you mentioned before we got on this panel.
Great, thank you. Did you have something to add to that, Meg? Oh, you were just...
To respond to the other question. Yeah? Okay,
Yeah.
good. Yeah, I think big question, not much time left to answer it. I think, I would point everyone to the Global Digital Compact, which was signed by UN member states last year, and that commits to promoting human rights within the context of governance of AI and digital health. And for, I think, those of us concerned about health, we can look towards the right to health, which is encoded in international human rights treaties, ratified by most countries, and commits us to upholding availability, accessibility, acceptability, and quality of health services, facilities, and information. We're a long way from achieving that for all, and I think precision health is something that is appealing for many, but I think for a lot of the communities that my project works for, they don't even have smartphones, they don't have electricity, they don't have Wi-Fi. We have a long way to go to bring everyone into digital inclusion. And we also have to think about how we do that while balancing the threat to the climate that AI poses as well. So we've got some big challenges to crack, I think, and I hope that we can take it forward using the human rights-based approach.
Great, thank you. And thank everyone. We're going to bring this session to a close. We have Plenary 1 immediately following this. So I would ask everyone to limit their coffee break to really benefit from what will happen in the next session. I would like to, first off, Wang, thank you for both your presentation this morning and your participation in this panel. And we look forward to seeing how the private sector can become a unified, singular force for our collective well-being. So this will be very exciting. Ruben, again, thank you about telling us where we're heading. The world we want is a world we have to really work to achieve. Mm-hmm. And so it's not just about technologies, as we've heard. It's about technologies that address not just our health, but our well-being in a collective way. We heard this morning on the video, AI is the future, but the future is ours to mold. And over the course of the next 2.5 days, we have an opportunity to ask ourselves, what do we have to do to mold the future in a way, in the realities of artificial intelligence, all of the other dramatic advances that are happening across science and technology. How do we engage that process in a way that gives us the world we want, in a way that also minimizes the unintended consequences? We live in a world that is made up of double-edged swords, and so the power of AI and the power of these new technologies are unquestionable, but their opportunity to generate unintended consequences are also extraordinary. And it's the act of molding that will give us the opportunity to create the world we want. So I thank everyone. Gabriel, I'm going to turn this over to you and look forward to Plenary 1. It follows directly after, and I do want to, I had an assignment as everyone is leaving. There is a QR code that I have to get the note. Well, you will be asked to evaluate each of the sessions. There's a QR code that we can find If the secretary can help me with that, where the QR code is, we will inform you. But with that, thank everyone. A big round of applause. Great.